fancy imaging portion. We'll just look at the basic, what do we look. So this is brachial plexus is not something that you would image every day, but it's something that you keep getting referrals to quite often. So what I'm going to do is, first we'll look at the MR protocol that we follow. Follow that up with normal anatomy, how does brachial plexus appear on MRI, and then go through the common pathologies. So when we talk of the pathology, the anatomy and the protocol, it's very important to get good quality images, because that's the first step. If you do not have good quality images, you will not be able to evaluate things well. Brachial plexus is a difficult area to evaluate because you have got a large field of view and curved surface and a mix of structures. You have bone, you have a lot of fat, muscles. So because of that, it becomes challenging. What we need to remember is we always need to begin with a sagittal T2 and axial T2 of the cervical spine, because the brachial plexus originates from the cord, the nerve roots. So it's very important that we include the cervical spine 2 sequences. One is the sagittal T2 followed by the axial T2. The axial T2 should ideally be something which is a 3D sequence or thin sections, like maybe cube or cis or fiesta, whatever it may be, because you want to look at the nerve roots very carefully. So it should be a whole slab. You cannot have vertebral body disc. It should be a whole slab plan. After that, we should do the coronal stir and T1, including both the side brachial plexus, a large field of view. Now here what happens is getting uniform fat suppression becomes a problem because of this large area to be covered. So for that, stir is better. But nowadays on the machines, you have these newer images like Dixon imaging, you have Ideal, depending on which machine you have, and they will allow you uniform fat suppression and become very useful. Otherwise, stir is the usual workhorse which you use. And a coronal T1, 2, including both sides brachial plexus, because you need to compare both the sides. Then we do a sagittal image, which is usually a sagittal T2 and stir. Sometimes we take sagittal T1. I'll come to that little later. That's in thoracic outlet syndrome. Contrast we give only when we are looking at mass lesions, at metastasis. Otherwise, normally in trauma cases, we do not give contrast. Even in brachial plexitis, we do not usually give gadolinium. MR neurography is an added sequence. If you have it, good, you can do it. But if you do not have it, do not worry. You can still evaluate brachial plexus well. So this is the MR neurography images that you get. Let's begin with looking at anatomy of the brachial plexus. So it has got 4 components: roots, trunks, divisions, and cords. RTDC. So the roots are the ventral roots of C5, 6, C7, C8, and T1. So these 5. Sometimes you can have contribution from C4 and sometimes from T2. You may have a pre or post fixed kind of brachial plexus, but usually it is C5 to T1. So the axial images you acquire from the cervical spine should cover from upper margin of C4 up to lower margin of T2 for adequate coverage. These nerve roots then go out of the spinal neural foramen extraspinally, and they form 3 trunks. C5 and 6 join to form 1 trunk. The C7 continues as middle trunk, and C8 and T1 form the lower trunk. Now these 3 trunks divide into anterior and posterior divisions each. And these again unite to form the 3 cords. So these 3 cords are lateral, medial, and posterior in relation to the axillary artery. And then these cords give out the various branches. Most important major ones are axillary, musculotendinous, radial, medial, and the ulnar nerves, which will further give branches. So the brachial plexus is the complete motor and sensory innervation to the entire upper limb. So that's its importance. We can imagine how important all the hand movements at the elbow, arm, all are controlled by the brachial plexus. Now, if we see here, the divisions are retroclavicular. Roots and trunks are supraclavicular. Divisions are retroclavicular. Cords and then further branches are infraclavicular. So this is important when we are trying to look at the anatomy on MRI. On sagittal images, it's very important to look at this anatomy. So first you have near the spinal canal, when you just come outside it, you have the interscalene triangle. Interscalene because it's between the anterior and middle scalene and the posterior scalene. So between these scalene muscles, you have the interscalene triangle. And this is where you have the roots and trunks of the brachial plexus. This is the subclavian artery and the subclavian vein is far away. As you come more laterally, you have the costoclavicular space. Costo, that is the first rib. Clavicle, that is the clavicle here and the space between them. So now we will see the subclavian artery and the vein near each other. And now we will see the divisions and the cords all around the subclavian. The cords will be around the axillary artery. Here you can see the divisions. And as you come more laterally, you have the retropectoralis minor space. So this is pectoralis major, this is pectoralis minor. So behind pectoralis minor here, you have the axillary vein, axillary artery, and around it you have these three cords. So these three cords, the one which is inwards towards the inside of the body is the medial cord, one which is outer is the lateral cord, and the one which is superior is the posterior cord. And this is the anatomy that we evaluate on sagittal images. When we come to MR neurography, as I said, it's not essential, but if you have it as an add-on, it always helps you. So this is it's not specific to only nerves. It's a non-selective neurography. You can use either a 3D space or a 3D cube stir or T2 sequence. And then you can get these images where you can see these roots, trunks, divisions, all of them on subsequent sections. So you can see here roots and then it's forming the trunks. Then you have the divisions and then you have the cords and then you have the peripheral branches. So all of them can be seen. It's a 3D sequence. So you can reconstruct it in various planes and have a look at it. So this is how the source images are and then you map them. The other neurography is when you have nerve selective neurography. So problem with this neurography is you can see the veins, arteries also look bright. So you can get confused and it becomes difficult at times. You may have a diffusion weighted image. So again, what we call as DWIPs. So you use diffusion weighted imaging. And now, so this doesn't look as pretty as your other neurography, but here you can see only the nerves and you can trace the nerves well, but then the image quality based on your machine can be difficult to get good image quality. So that was it about neurography. Rest of the images, I'm not showing you neurography, I'm showing you the normal imaging. So here's the normal anatomy. What you have is the T1 weighted image. So initially you start seeing the roots and then they form the trunks. Behind the clavicle, they form the division. And distal to the clavicle, the cords and the main branches are seen. So roots, trunks, divisions, and cords. One important thing to remember is, on stir image, the nerves always show little slight bright signal. Not too much, but very little hyperintense signal is normal. And then here you have the axillary vessel. So sometimes you can have a lot of artifacts also. So you need to make sure you're putting the sat bands and those other technical parameters carefully. Sagittal images, let's look at the anatomy. This is Sag T2 weighted image. I'm coming from medial to lateral. So here I can see the nerve roots, the dorsal root ganglion. You can see here. So from the foramen, the nerve roots have come out. As you come here, this is the interscalene triangle I spoke about. So this is the scalenus anterior. This is the scalenus medius. Between them is the subclavian artery. The vein is more anterior. So this is subclavian artery. And just above that, you can see the roots and then later trunks of the brachial plexus. So it's very important to have non-fat sat sequence also. Because imagine if this was stir, everything would look dark. So yes, stir sequence is very important to detect abnormal hyperintensity. but it doesn't show you the anatomy. Non-fat-sat sequence, fat outlines all these nerves and shows you very well. As I come further laterally, this is the costoclavicular space. This is the first rib here. This is the clavicle. This is the subclavian vein, and this is the subclavian artery. And now you can see the divisions of the brachial plexus all around it. So again, keep non-fat-sat and stir sequence side by side. Look on stir for hyperintense signal. Look on non-fat-sat sequence for the anatomy. Now, as you come more laterally, you can see three of them: medial cord, posterior cord, and the lateral cord. Here you can see very clearly, this is retropectoralis minor space. This is the pectoralis minor muscle. This is the axillary vein, and this is the axillary artery. You have the three cords clearly: medial cord, posterior cord, lateral cord. Okay, exactly what we saw in that picture that I showed you before, the diagram. Now, having looked at the anatomy, let's look at the pathologies. Traumatic, most common that we get referral for, followed by inflammatory, and then tumors. Whenever somebody comes to you with brachial plexus injury, so there are two situations. Usually what we image are all patients who have, say, a road traffic accident or fall from somewhere. So basically the arm has got stretched, and these would lead to brachial plexus injury. And invariably these patients are scanned slightly later, because initially they have other fractures, they have maybe head injury, other injuries which are first dealt with being an emergency. And after some time, they come to us for MR, which in a way works good for us, because in acute injury, there is so much of edema and hemorrhage that MRI becomes very difficult to sometimes make out findings. So that slightly later works out well for us. At the same time, you don't want it too many months late, because then the muscle atrophy will set in and the management would be difficult. Other situation is obstetric palsy, Erb's palsy or Klumpke's palsy. But frankly, we do not get too many referrals for that in our practice. These babies are not scanned for brachial plexus because they already know there is a brachial plexus injury. But later, when they plan the surgery for the glenoid version for rehabilitation, that time they send us for shoulder scans. We do not image brachial plexus of babies for obstetric palsy much. There would be few referrals sometimes. Now, why is MRI so important? Because the whole idea in brachial plexus injury, you want to diagnose where is the level of injury. Is it preganglionic or is it postganglionic? Preganglionic means has the nerve avulsed off or come off from its spinal cord attachment, right from its spinal cord attachment if it's come off. That is before the dorsal nerve root ganglia, that is preganglionic injury. If the injury is after the ganglion in the neck, in the axillar neck, that is postganglionic injury. So why that is so important? If it is a postganglionic injury, they may need to do nerve grafting or they can do nerve repair to repair it. But if it is a preganglionic injury, that's not possible. You can't take the nerve root and attach it to the spinal cord. So instead, that patient later they might plan nerve transfer. So what do they want to do? They want the patient to retain his shoulder movements and biceps function. So they'll take some other nerve, like say intercostal nerve, musculocutaneous nerve, and attach it to the suprascapular nerve. So take nerve from somewhere else and try to make up for the function of the shoulder and biceps. So the surgeon wants to clearly know, is the injury preganglionic or is it postganglionic, because it changes their management. Sometimes patients can have both pre as well as postganglionic. Second thing they want to know is, what is the degree of injury? Okay, it is postganglionic, fine. Is it in continuity? So is it just a neuropraxic injury? The nerve has got stretched, it's got edematous, but it still continues. That means with rehab, with time, it will recover. Or is it disrupted? If it is not in continuity, if it is disrupted, then the surgeon needs to go in, might do nerve graft, nerve repair, whatever the case may be. So this is exactly the two things they want to know. Preganglionic or postganglionic? Is it in continuity or is it disrupted? So let's look at examples. So here we have so as I said, the whole main idea is to try to divide between them. So here we have a preganglionic injury. So what do I see? This is the sagittal T2-ated image, little obliquely. You can take oblique ones along the nerve root also. That can also help you. And this is an axial image, and you have the pseudo-meningocele. You can see this CSF collection here very clearly at these two levels. So the nerve root has got avulsed from the cord, and the CSF has leaked out, forming a meningocele, pseudo-meningocele. So if you see a pseudo-meningocele, life is very easy. More likely there is a nerve root avulsion. But important, pseudo-meningocele does not mean 100% there is root avulsion, and you can have root avulsions without pseudo-meningocele. So it's not like a absolute thing. Here again, another patient, you can see these pseudo-meningoceles on these images. You can see nerve denervation, the muscle denervation, supra and infraspinatus. Here again, you can clearly see the pseudo-meningocele. This is normal side. And here you can see a pseudo-meningocele at C7 nerve root as well as at C8 nerve root. Both levels there is avulsion. Here again, you can very clearly see this well. So sometimes you get confused because there may be small perineural cyst or something. So look carefully. Are you seeing any nerve root traversing through it? If it's perineural cyst, you will see nerve root. If it is a pseudo-meningocele due to nerve root avulsion, you will not see any nerve root traversing it. So here there are 3 levels of pseudo-meningocele nerve root avulsion. In this patient, the roots had come off. So you can see these roots on the left side. So that's why these thin sections are important. Here you have, but at this level it had come off and it had got retracted all the way into the neck. So the nerve root, instead of being here, has got retracted into the neck. Now, this is the tricky one, where when you look carefully, you can see the roots. You can see roots on the left side, but on the right side, you do not see any root at all. That's why you need thin sections. That's why you need good T2 3D sequence. And here you could see some signal. Now at such times, another clue which is helpful. You can see this multifidus muscle here, the posterior paraspinal muscle here. You can see this is normal and this is atrophic. So if you have atrophy here, in addition to your supra and infraspinatus muscles also, you know there is an injury preganglionic. So that increases my confidence. Yes, I don't see the nerve root. I see multifidus atrophy. This is a preganglionic injury, though there is no pseudomeningocele. Next, coming to postganglionic injuries. So here, what do I see? The nerve roots are fine, but here I can see fully disrupted. The nerve somewhere around the level of trunks, it's completely disrupted, forming something like a nerve retraction ball surrounded by hematoma and fluid. So this is completely disrupted brachial plexus. Here you have postganglionic injury, but in continuity. Nothing is disrupted, but you can see the nerve, the trunks, divisions and cords are swollen, and even the branches swollen, showing bright signal compared to what we saw earlier. So this is neuropraxic injury, stretch injury. So you can even give the Sunderland grading based on, so that's available, the Sunderland MRI grading. There's a very nice article in Indian Journal of Radiology and Imaging, for which I was the guest editor, article by Dr. Avnish Chabra from US, where he's given that grading, which one can give here also. Here again, now you can see that was more divisions, cords. Here you have the trunks and the roots here, extra spinal roots and the trunk swollen, showing bright signal, but at the same time continuous. They are not disrupted. Here again, you can see these roots are swollen, showing bright signal compared to the opposite side always. And you can see clavicle is fractured here, displaced, and you can see how this one cord, can you see this? This is the posterior cord, this is the median cord. So specifically the median cord is swollen and showing bright signal. Here you can see complete disruption, postganglionic. Somewhere here around the trunk divisions level, it's completely disrupted. You don't see any brachial plexus at all. Sometimes you may get a neuroma formation. So this was a child, in fact, with obstetric palsy, and they did image them. So you can see this was, I think, 3, 4, 5, 6. Yeah. So at C6 nerve root, you can see the C5, C6. So C6 nerve root shows a fusiform swelling. So that's neuroma formation due to the prior injury. This was a child whom we imaged with Erb's palsy. So you can see again, this side, there is no abnormality. Here you can see, I think this is again C6 nerve root and some component of C5. They are swollen, thickened. Again, here you can see all of them swollen, thickened, showing bright signal. This patient had both pre and post ganglionic. So here you have the pseudomeningocele with rupture of the avulsion of the nerve roots. But also if you see distally, you can see these, the trunks and the divisions here, they are completely swollen. Even the cords you can see here, the trunks here, sorry, you can see them swollen, showing bright signal. So there was both pre and post ganglionic injury. Here this patient, you can see there was injury and there was all this fibrosis and hematoma. Like this was done few months later. There was denervation changes. You can see supra and infraspinatus shows edema. Early changes, you show edema. Later you'll get atrophy. So you can see all this fibrosis and hematoma completely engulfing the brachial plexus. You're not seeing individual components. It's all encased by the scar tissue. Here, this patient, you can see there is signal which is more here in the axillary nerve if you look at it. Because of this fracture in the quadrilateral space, there was axillary nerve injury. This was a lady who had cosmetic surgery for axillary tail breast tissue resection, and after that developed median nerve symptoms. And you can see here, this level there is scarring and edema, and this is the median nerve. You can see this area gave contrast in this patient. All this scar tissue was enhancing, and this was the nerve which was completely encased by that. And these are the surgical changes out here. This was a patient who had a clavicle fracture. He had an injury to the subclavian artery at that time, which was treated. But now, few years down the line, few months, little later down the line, he came with brachial plexus symptoms. And what do we see? We see a large pseudoaneurysm of the subclavian artery, and that was causing mass effect on the brachial plexus or brachial plexus symptoms. Next, coming to non-traumatic brachial plexus pathologies. So trauma, quick recap, pre-ganglionic or post-ganglionic, in continuity or not in continuity. The 4 most important questions that we need to look for. Non-traumatic, we usually see brachial plexitis. The etiology is not always known. It's supposed to be an immune-mediated inflammatory reaction. Usually maybe following some viral infection, maybe idiopathic, could also be seen with hypertrophic polyneuropathy, familial, and we do see them fairly common. One of the brachial plexitis common causes radiation plexitis. So patients who have received radiation for breast malignancy or maybe some neck malignancy, here you can see this is normal on right. On left, all these roots and trunks are swollen. They are showing bright signal, but they are continuous. This was a patient with radiation for breast malignancy. You can see distally, that is, the cords and the branches now are swollen, showing bright signal. You can see here all this bright signal, but you don't have any mass. It's all just diffuse swelling and bright signal, radiation, fibrosis. This was an orthopedic resident at our place who came with, he had severe pain in his shoulder. He thought it's probably due to some sprain or something. And then after a few days, he developed weakness in his upper limb. He was not able to comb his hair. He was not able to button his shirt. And what we see is this brachial plexus here is swollen, showing bright signal. So characteristically, patient has pain followed by weakness. Again, here you can see brachial plexitis, similar findings. Here you can see swollen bright signal. This was interesting. This was a lady who delivered a child and about a week later developed weakness in both her upper limbs, which is quite scary. What MR showed is, again, bright signal in both brachial plexus, which are swollen. And then we came across this entity called as postmortem brachial neuritis, which is a known thing, immune mediated. And then she recovered with rehab, and I think she was given some steroids, and then she did recover from it completely. Tumors, you may have a nerve sheath tumor like this, spindle shaped fusiform along the brachial plexus, lymphoma. So when you have a tumor which surrounds a vessel completely, you are thinking of lymphoma or leiomyosarcoma. This turned out to be lymphoma. So all the brachial plexus was also involved. Breast CA with metastasis. So this patient had lymph node mets and mets around the axillary nerve. Compare it with the radiation fibrosis I showed you earlier. Here you can see it's a mass. It's a clear mass. There it was not mass. Here it's a well-defined mass. So we can distinguish between the two. Again, metastasis, and you can clearly see a mass lesion also involving the clavicle. You can see this clavicle, and that soft tissue associated was involving the brachial plexus, metastasis. Pancreas tumor. So these patients may first come to you with radiculopathy or with brachial plexus like symptoms, and MR will show you the superior sulcus large lesion involving the roots and the trunks of the brachial plexus. This is Pancreas tumor. So we as radiologists may be the first people to be diagnosing this at times. Last about 5 minutes, let's speak about thoracic outlet syndrome. This is a challenging area because it's not always easy for us as radiologists to make the diagnosis. It's a dynamic process, that's important. So dynamically, either the nerve or the artery or the vein is getting compressed during its extent from thorax to the upper limb. And this happens especially during elevation of the arm. So it's basically a clinical diagnosis. They would do the Adson's test. Clinically, the diagnosis is made. Imaging is used to demonstrate what is causing compression and where, but it's not always easy. You can do a plain radiograph. That's what you begin with. Try to look for cervical ribs. Ultrasound is good. You can do dynamic maneuvers to see arterial compression. CT angio may be done. MR plain and with angio may be done. So it's a whole constellation of things, and sometimes with all of these also you may not exactly get an answer. The three spaces I already spoke about: interscalene, costoclavicular, retropectoralis minor. Again, quick recap: interscalene, costoclavicular, and retropectoralis minor space, normal. So what we do is we obtain sagittal T1 weighted images through these three areas in your routine position with arm by the side. And then we acquire sagittal T1 weighted images from the midline of the spine to the axilla with the patient's arm completely elevated, hyperabducted. So completely straightening your shoulder, arm. And again, you look at these areas. Are these areas getting narrowed? Is there something causing compression? So interscalene and costoclavicular. So just let's look at costoclavicular here. Look at this costoclavicular space. On arm elevation, it normally also gets narrowed. Okay, so just seeing narrowing is not always thoracic outlet syndrome. Retropectoralis space obviously doesn't get narrowed. So just few examples, I'll show you what we have seen in our practice. It could be bone abnormalities, it could be soft tissue abnormalities, or sometimes you don't find anything. So here, this patient had cervical rib. You can see here clearly a larger one on the left, a smaller one on the right. This is the cervical rib from the C7 vertebra. This is the costoclavicular space in neutral and here in hyperabducted position. And we could clearly see the artery and the brachial plexus structures getting significantly compressed and clinically. So as I said, it's first a clinical diagnosis and we are the next step. This was another interesting case where first this was done outside. Somebody had done a Doppler because this patient was getting some discoloration of fingers of the hand. And they said there was thrombosis in axillary, brachial and radial artery. And they advised a CT angio. CT angio was also done elsewhere and it showed the same kind of findings, but they were not sure what the cause was. Thoracic outlet syndrome was suspected. So we did this. And on our scan, what we saw MR, this is in neutral position. This is in arm elevation. Can you see this costoclavicular space is getting very narrow? And can you see some bony projection like thing was coming out here, which seems to be compressing all of this. We didn't know what that was. So we got back the CT, CD, recon that. And what you can see, there was hypoplastic first rib fused to the second rib. So this bulbous portion here was what was causing the compression. This here, if you look at here in the, just about distal to the interscalene triangle, here in neutral and here you can see this, you'll kind of have to believe me, there's this thin hypointense band. You can see this thin structure here. So we called that as a fibrous band and it turned out. But if it is thin, it's very difficult on MRI to make out. We had a patient, he was a canteen worker in our hospital. Clinically, they were sure it was thoracic outlet. Everything was fitting in. We could not find a fibrous band. But they operated and yes, there was a fibrous band. So thin ones are really difficult. Here, this patient had this large osteochondroma, exostosis. You can see from the rib and see how it is compressing. So this was the brachial plexus. So how it is near it in neutral position and in elevation, it was compressing it and had to be operated because of the mass effect it was causing. You can do MR or CT angio with the arm elevated to try to look for obstruction of the artery. So to conclude, I would say MR is the imaging modality of choice. You can evaluate the brachial plexus entirely. Earlier, people would do CT myelogram to look for nerve root avulsion. We don't need that anymore. If you do a good quality MR, you can see it very well. And you can evaluate the postganglionic brachial plexus also, which CT cannot. Ultrasound of brachial plexus is not easy. It's a deep structure, not always easy to evaluate. So MR is the best modality. Yes, there are certain pitfalls, sometimes difficult, but if we go by the basic principles, it's not difficult to make the diagnosis. Thank you very much. And this is the article that I have written in Indian Journal of Radiology and Imaging. And it kind of gives all that I spoke about today in more detail. So all of you are welcome to look at it. And any questions, I would be more than happy to answer.